I'm going to talk today on gastric motility study. My name is Simin Dadparvar, Professor of Radiology in the Division of Nuclear Medicine and Molecular Imaging at Temple Health System in Philadelphia. The GI motility studies are including esophageal transit study, gastroesophageal reflux study, gastric emptying study, small bowel transit study, and colonic transit study. Gastric emptying study is the gold standard functional imaging for the diagnosis of gastric diseases. Gastric anatomy is including the lower esophagus, then cardia in here, and then fundus of the stomach, then body of the stomach, then antrum, and then pyloric canal coming for the pylorus and ending with the duodenum. The stomach function is the proximal function of that in the fundus function, accommodates and stores food, and its tonic contraction is responsible for liquid emptying. Distal stomach, antrum, has phasic contractions responsible for solid emptying. Antrum mixes and grinds food into small particles to pass through the pylorus. Clinical indications for radionuclide gastric emptying includes patients with diabetes and with postprandial symptoms, the diabetes and poor blood control, non-ulcer dyspepsia, severe reflux esophagitis, unexplained nausea and vomiting, assessing response to motility drugs, as well as the pre-bariatric surgery, and also post-lung transplant. I'm going to touch some of these studies in this lecture. Pharmaceuticals that they are delaying gastric emptying, they include on top of the list opiates such as Percocet, Percodan, OxyContin, alcohol, psychiatric medications such as Valium, Librium, tricyclic drugs, and also the neuropsychiatric medications such as levodopa, Ativan, and tricyclic drugs, and Thorazine, which is used for the patients with the psychotic disorders. Gastrointestinal medications, anticholinergics, and sucralfate, they all delay the gastric emptying. Reproductive, such as contraceptives and progesterone, are the other ones. Cardiovascular, such as calcium channel blocker, beta-adrenergic agonists, and also respiratory drugs such as theophylline and isoproterenol, they are all interfering and delaying gastric emptying. Therefore, the list of the medications are necessary to know which drug the patient is on. So the gastric emptying studies with sealed solid and unsealed liquid is done when we usually include 500 microcurie of technetium sulfocolloid. The dose range is from 300 microcurie, but we can go up to 2 millicurie. I will tell you when. And then after that, we also give the patient, if we need to give liquid, we include the liquid with 125 microcurie of indium-111 DTPA. And the dose range of DTPA is usually from 100 to 300 microcurie. The camera is being used is large field of view, and we put the camera usually peak on the technetium peak with 20% window. If we are going to use indium, we are also going to have the peak of the indium with 20% window. And then the collimator that we use are the lip collimator. If we are using the indium, then we use the medium energy collimator. The computer is 60-second static images that we take for both anterior and posterior views. Imaging procedure is that patient is instructed to eat within 5 to 10 minutes. Acquisition protocols is that anterior and posterior images are done for each 60 seconds of the abdomen are required with the patient standing. And then we continue acquisition of the images at 0 time, 30 minutes, 60 minutes, 120, 180, and 240 minutes, each one anterior 1 minute, posterior 1 minute. If the patient cannot stand, if you have a very sick patient, you can put the patient in the LAO position in the bed and then take the image twice and count it as anterior and posterior images. Then 2 image pair sets are acquired on 2 peak sets of the technetium and indium, as I said before, and the geometric count at each time is measured, which the geometric count, that is the reason you are doing anterior and posteriorly. The formula is the inherent in the computer. At time 0, the activity is measured as 100%. The counts at different times will be deducted from the time 0, projecting percent activity left at different times. If the patient cannot swallow solid, a liquid-only meal is reordered. We pour 300 cc of Ensure Plus and inject 500 microcurie of technetium sulfur colloid into the liquid. When indium 111 oxime or indium 111 chloride is substituted as the label, 125 micron of the microcurie of indium is going to be used, and then with medium energy collimator. Dynamic gastric protocol, when we do that, this is unique to Temple University Hospital, which is a center of gastric motility studies, and it is 2 millicurie of the technetium sulfur colloid. We do static in anterior and posterior images, each for 1 minute, and additionally, we do the dynamic imaging in LAO position, each for 10 minutes at times 0, 30, 60, 120, and 180, and 240 minutes. That really requires the patient's cooperation to be able to do a long-term imaging. Gastric emptying studies with cornflakes and sometimes oatmeals have been performed in other institutions, but we do not have any normal gastric emptying numbers have been published for those. The patient instruction for gastric emptying study is that the patients are going to have 2 pieces of the toasted white bread and 2 packs of jelly and liquid egg white, or 2 eggs along with the glass of the water. And this is unlabeled water. The meal will be mixed with a small amount of radioactive material. Prior to this meal, you should not eat at least for 8 hours. Hold off any medication which may delay or enhance gastric emptying. And the time to eat is for 10 minutes. If you are allergic to eggs, please let us know, and we will replace it with Ensure Plus or Boost Plus that we can use it instead. And you will be in the Department of Nuclear Medicine for about 4 up to 6 hours. Now, how do we report solid gastric emptying studies? We write down how much the patient has ingested. Preferably, the patient has to ingest 100% of the meal. And then the patient is on what medication, which may interfere with our gastric emptying study. And then if the patient is diabetic, what was the fasting blood glucose level at that time, up to the blood glucose of 275 in our department. We have been using that. We have not interrupted any studies. if the 270 or below is the blood sugar. Then we look for the fundal accommodation, and sometimes the fundal accommodation is called fundic accommodation. We look for the remaining activity of the stomach at 2 hours. Normal is less than 60%, and remaining activity at 4 hours with the normal less than 10% for the solid gastric emptying. When you are looking at this image, this is a poor fundal or poor fundic accommodation. What it is, instead of food going to the fundus of the stomach, instead ends up with the area of the antral. So this is a patient with poor fundal accommodation. It has been shown that some gastric problems, the patients cannot, the fundus of the stomach cannot accommodate the food, and that's the reason they get into problem. This is a patient with normal gastric emptying study. You can see a very good fundal accommodation. You can see the activity coming to here. When you look at it in here, the patient at 118 minutes or 120 minutes has 60% emptied, and then only 40% is remaining. And at 4 hours, only 2% is remaining. So this is a perfect normal gastric emptying study. This one, you see the patient is having a good fundal accommodation, but when you look at it in here, the patient is having this one also is the normal, that the patient it has 23% remaining at the 2 hours, and 3% remaining at 4 hours. What happens if at 1 hour the patient has less than 35% remaining? That would be a rapid gastric emptying. So how do we report high fat liquid gastric emptying? Again, we report how much the patient has ingested and medications that they may interfere. We also report the blood sugar level. But then in here, we report every hour how much is left in the stomach. So remaining activity at the 1 hour should be less than 80, at 2 hours less than 40, at 3 hours less than 20, and at 4 hours less than 10%. So in here, what you are looking at, you see that the patient, don't check the patient's fundal accommodation by the liquid, but what you are looking at, this patient at 1 hour has only 19% remaining in here. At 2 hours, 80% is remaining in here. And then at 3 hours, much more than 40%. At 4 hours, you see that the patient is having almost 60% is remaining. So this patient has definitely delay in the liquid emptying, which is the Ensure and Ensure Plus. Now, if you want to check indium DTPA, the emptying of indium DTPA at the same time that you are giving the solid food, then you only check the patient's activity of how much is remaining at 1 hour. And it has to be less than 50% of the liquid, which is water, remaining at 1 hour. This one is at Ensure Plus. So the combined solid and liquid gastric emptying with the small bowel transit is being done very often in our department, and they are independent of each other. So we give the patient egg sandwich with 500 microcurie of technetium sulfocalorie. We give 6 ounces of water with 125 microcurie of indium DTPA. We write down that how many percent of the food was ingested, medications that may interfere, and also we look at the fasting blood sugar, and we solid meal results. We check it at 2 and 4 hours, as I said, at 2 hours has to be less than 60%. At 4 hours is less than 10%. And we look for the liquid meal result that has to be less than, in 1 hour, less than 50%. We look to see that how much of the activity has arrived at terminal ileum, which has to be more than 40%. Okay, so now then we do in our department, we do a study which is the dynamic antral contractions. It has been shown that some patients that they do not respond to therapy, they are having the problem with the antral contractions. We usually do that with 2 millicurie of the technetium sulfocolloid. And again, we record how much ingested, medication, fasting blood sugar, and we look for the fundal accommodation. We look at how many percent is remaining at 2 hours, how many percent at 4 hours, and then we check the antral contractions at time 0, 30, and 60 minutes, and they are usually for each one is done for 10-minute image, and then we check it. The contractions per minute are supposed to be anywhere between 2.8 to 3.2. So when you are looking at this one, we are looking to see, we are recording to see that how the emptying is happening and what is the episode of contractions. That plays a major role for decision of what type of medication they want to give to this patient. This is the study of the antrum, and you see that we put the region of interest in here. You see that this patient is having almost irregular activity, and what you see that they are high amplitude, and we count the number of the peaks, and we say how many percent, how many peaks the patient has within per minute, because this is done over a 10-minute period, and then we decide that if it is within the range and it is normal or abnormal. This is another normal gastric emptying that I wanted to share with you that we have done on the same patient that we looked for the antral contractions too. So this patient is a patient that shows at 2 hours has delay in emptying, which in the patient 78% instead of 60% is remaining, and at 4 hours 7% is remaining. The reason why I'm sharing this with you to show you that the patients may have different responses at different times, and everything must be recorded. This is a patient with a very good, fundal accommodation. You can see that this patient has at 2 hours 28% only emptied. That means that the patient has 72% remaining, which is more than 60%, and 30% remaining at 4 hours, which is way more than 10%. We have a lot of patients with diabetic gastroparesis that they have this kind of finding. This is another patient with good fundal accommodation, but what you are looking at is normal at 2 hours, less than 60% is remaining, but at 4 hours, the patient has 20% of the activity remaining. On the other hand, this patient, after treatment that the patient was treated, then turned to be normal at both 2 and 4 hours. So we can follow up these patients to see that if they are responding to therapy or not. So reporting gastric solid emptying is the way that we have reported that. We do that initially, and we do it at the follow-up, and then we say that the patient has responded well to therapy or not. And liquid, fat emptying is this way. And again, in our department, if anybody refuses to eat eggs or says, I'm allergic to eggs, we use Ensure Plus, and we use all these criteria for reporting. And this is the combined solid and liquid, and with the 6-hour study that I reported to you. So, and this is the dynamic study that we do just like the solid emptying first, but with 2 millicurie, but we do the antral contractions at 0 minutes, 30 minutes, and 60 minutes, and we come up to report that if the antral contractions are normal or not. Causes of rapid gastric emptying could be surgical, like pyloroplasty, Billrot 1, Billrot 2, sleeve gastrectomy for bariatric surgery, Roux-en-Y surgery for bariatric surgery. The hormonal, like thyroxine, like the patients that they are they are put on thyroxine medication, motility and enterogastrone, they are also causing the rapid gastric emptying. Diseases such as the renal ulcer, gastrinomas like Zollinger-Ellison syndrome, and hyperthyroidism, they all would cause rapid gastric emptying. So the gastric emptying study, the person who is reporting that has to know all about the patient. Usually the rapid gastric emptying means that what is left in the stomach is less than 35% at 1 hour. Pharmacological therapies that they are being used for the gastric studies for the, after the patient has shown problem is the prokinetic medications for treatment of the gastroparesis, metochlorobromide, Reglan, domperidone that, is being used, and erythromycin. So please take a look at that. And when you are reporting the patient, say that what the patient is on. This was the study that was done in our department. This was a gastric emptying study in patients going through bariatric surgery. So what we did pre-bariatric surgery study on these patients, and then we followed them with the post-bariatric surgery with their symptoms. So patients undergoing bariatric surgery such as Roux-en-Y and sleeve gastrectomy may experience complications of abdominal pain, distension, and delay in gastric emptying post-surgery. So that is the reason the surgeons, they send these patients to our department to see that if these patients are at high risk, such as having the gastroparesis before the surgery, and if that would dictate what is going to be the outcome post-surgery. So evaluation of the gastric emptying prior to surgery was performed to predict the patient's outcome. This was a patient that had normal gastric emptying, good fundal accommodation. You can see that at 2 hours has 49% remaining, and at 4 hours only 5% remaining. So that was a very good study. And this patient had a normal post-operative outcome. This patient had a good gastric, fundal accommodation. And when you look at it, at 2 hours, the patient has 77% remaining, which is way more than 60%. And at 4 hours, 27% remaining, which is way more than 10%. And this patient, on the abdomen after the surgery, had the problem that had the complaint of abdominal pain and post-operative complications post-surgery. This is the Temple University Hospital, which I am working in Philadelphia, and I hope that if you are in Philadelphia, you will come and visit us. Thank you.